funny. When I was saying goodbye to my kids, my 5 and 6-year-old, I told them I was coming to Santa Cruz, and they're like, "Mommy, you can't go on a Santa cruise without us. You're gonna tell Santa we've been good?" To start out, that was real. That did happen. She did say that. Okay. So, and thank you for going over all of those things. So, I ever since even I was an undergrad, I knew I wanted to be a psychiatric pharmacist because I have a sister that had traumatic brain injury from a car accident, and I always wanted to be there to help patients, experiencing the same things that she was going through, because I did see that a lot of people weren't there to help her. Even family members pushed away, not realizing that the struggles that she had were not to what she was doing, but it was due to the traumatic brain injury. So that's what I always do. I want to be there for my patients and for everyone, to help everyone be more educated about your medication, so that the more informed you are, the more you can go into those meetings with the doctors and make good decisions and have it be a partnership instead of a one-way thing. So thank you again. So we'll go ahead and get started. And I have to turn this on. All right. So disclosures, I do not have anything to disclose. I have no financial relationships with anything, except with my husband, I guess. Being really funny. Just to let you guys know, I will be speaking about off-label uses of some of the medications, because it's important for you guys to know, because a lot of the times the doctors do prescribe things off-label. So if I don't tell you guys that, you guys are going to miss out on a whole chunk of what's going on when the doctors are recommending medications to you guys.
What does that mean? What's off-label?
Oh, fantastic. Great question. Awesome. All right, so off-label means, so usually when a medication gets approved in the clinical trials, we're looking at a certain, on the label it says this is approved by the FDA for, let's say, treatment-resistant depression, or for just treatment of depression, or as add-on for depression. So sometimes we have those labeled indications that the drug company actually went out and sought the approval for, but then there's off-label uses where there's been some studies, but the company hasn't actually gone out to get those indications approved. A lot of times you'll see that with medications that are already generic, that have been out there for a long time. The company may not have the incentive to go through the whole process of getting a labeled indication for it. So we do use things a lot of times off-label. It doesn't mean that it doesn't have evidence behind it. It just means that the company didn't go through all those steps to get the approval, but we know based on the literature and educating ourselves that this is a potentially effective and good use of the medication. Does that answer the question? Awesome. All right. So just a couple things. We're not doing a CE or anything like that, so there's really no objectives, but the overview of tonight, I know we have a mixture of audience, right? So we have anywhere from family members to patients to healthcare providers. So it's going to be, if you guys want me to go more in depth into things, I could go even more in depth. So I'm going to leave it up to you guys, and then whatever questions that you have. But generally, these are the key things that I want you guys to be able to take away is throughout it, I'm kind of going to emphasize things, especially the next slide is going to show you guys, when you go into that appointment, what are some things, at least at a minimum, you should be asking the doctor before coming out of that appointment. Understanding how these medications work is an important thing as well, and what to expect from the medications, especially sometimes with how long does it take to see the effectiveness of the medication. After that, we have special considerations with specific medications. So I'll try to point out to you guys my own little clinical pearls with them. It's just that with them, there's certain things that you should be able to take away to take the medications even more effectively, or know why would the doctor pick one possibly over the other for you when they're recommending it. And then if they're not bringing stuff up, it's like, well, here's another option that I could potentially bring up. Is this a good medication for me next to maybe consider? And then side effects, unfortunately, there's nothing out there, not even, I don't know, the purest thing in the world. Everything has side effects, right? But it's always the benefits versus the risks. So we're going to go over some of those with you guys. And I always try to take it with a grain of salt because, sometimes when you list all the side effects, you're like, it could be a little overwhelming, right? So we'll go through them together. And then the importance of adhering to your medication. So I don't have a specific slide, I don't think of in this deck on that, but it's something that the whole presentation should be building on that. I know Carol mentioned the love and hate relationship with the medications, and it's because we know that even one medication can be hard to remember to take, but I know pretty much most of my patients are on multiple different medications that they have to take to help control their symptoms, right? Yes?
When you're Googling different medications and side effects, etc., do you have a preferred website, or do you have an opinion about the different websites that come up?
Okay.
Like drugs.com, WebMD, etc.
So Googling is not good, okay? Googling is absolutely not good. What's funny is that even, I think the pharmacists are the ones who utilize the most drug databases and resources. Even the doctors, I've seen some of them use Hippocrates. I don't ever go to Hippocrates. Like, I do Lexicomp, Micromedics, Facts and Comparisons. Those are my go-to pharmacy databases, but those are for healthcare professionals. So it goes back to, I think NAMI has some really good online resources for patients that goes over, this is the medication, these are some potential side effects. And then you have the package insert that the pharmacist gives you. I think those are probably the most appropriate resources. And then from there, talking to your pharmacist. I know that maybe the doctor may not be as accessible, but talking to the pharmacist if you're concerned about any. And then obviously let your doctor know if you're having side effects. But if you can't reach them immediately, you can always reach out to the pharmacist. I don't know if that answers it's okay. Don't Google. I've done that before, so when my kids get sick, sometimes I'm like, what are these symptoms mean? I'm like, I'm just going down a rabbit hole, right? Because you're like, okay, it's making me think the worst things, and this may not be the case, and it's not the right thing to do. So there's really good resources, especially for herbals and supplements. So most of the physicians don't even know that natural medicines is the one that the pharmacists know of, and that one is really good if you ever have questions, because pretty much a lot of the herbals and supplements, they can have side effects. Some of them could worsen conditions, or they can cause the medications to not work as well, or potentially cause the levels to go too high. We're going to talk about in a little bit that there's one that is used for depression that can interact with a lot of our medications we use for depression and be dangerous. So the pharmacists do have access to all of those databases to help with that. Okay, did that answer your question? All right, awesome. All right, so what questions should you guys think about when you're going to that meeting? So, it's not my phone. Okay, I'm like, it's not me. All right, so one of the things that I realized when I'm doing my medication education groups, that patients, even the littlest side effect if you're having, don't be afraid to bring it up to your doctor, especially like if you're going to that visit, it's coming up and you're seeing them, bring it up, because it could be something more than you think, right? So I always have patients in my med ed groups bring up side effects that they're like, oh, I didn't think to tell my doctor. I'm like, no, these are all things, they won't know until you actually tell them. They don't read minds, so it's whatever you share with them, that's what they know. So make sure nothing is too small, let them know. And I know that a lot of the doctors are probably on a time crunch, and what I heard before at the beginning of the presentation is that we even have a lack of providers, right? So you can imagine how short that time period must be when you go see the doctor, when they're trying to see a lot of different patients, and they're just like, okay, we're just going to do this. And sometimes I have patients who say they don't feel heard sometimes when they go into those visits, right? And it's not, a lot of times I let my patients know, they have a lot of patients to see, but that's what we're here for. So where I'm a support for the patients. We have a nurse practitioner who's a support for the patients as well, and then we have nurses around. So that's in the partial hospitalization program. But it can be, having those resources can be hard. So going into that appointment and maximizing that time, right? We want to know, one of the things that's important to know is, why are you taking the medication? What is it used for? Okay. We talked about earlier off-label uses. So I have patients, and we'll see in a moment, frequently they get, for example, how many heard of Risperdal? Okay. How many know Risperdal can be added on for depression? Okay, so I see maybe a third of the hands that went up. So I have quite a few patients who get very low doses of Risperdal added on for depression to their antidepressant, and it works really well for them, but They may not. So the pharmacist may just be reading the handout and say, "Oh, you're using this to help you with hearing or seeing things that are not there." But that's not the case. So they're using it for depression. So knowing what your medication you're using it for is really important, and it helps you be able to take it better. Yes.
So my son is nonverbal autistic, and they prescribed that to him. And I mean, how do you recognize if he's depressed other than the mommy factor? I mean, what other reasons is it for?
So that's an excellent question.
I
So
don't think that he sees things.
no. So based on the diagnosis you gave me, so we do use it in children living with autism for behavioral, to help with the behavioral disturbances and everything. So that kind of helps calm that down. Yes. Her question was, would you like me to repeat? So she has a son who has nonverbal autism, and her son takes Risperdal. So she was wondering, he doesn't have depression. What is he using it for? So it is used in that
What I know is it is used for is maintaining his attitude.
Yeah.
His demeanor, or if we're going to be going someplace special, whether it be out to dinner or Disneyland, it just keeps him kind of flatline.
Yeah.
Or when he doesn't sleep for 3 days.
So it prevents him from not sleeping for 3 days, right? Yeah. So we do utilize it for behavioral, to help with those things. It's just as you mentioned, exactly, and for autism.
And then how long do you recommend that they stay on that with all the side effects? I mean, I haven't noticed any like depressive enlargement and things like that, but he's been on it. He's 23 now. He's been on it since he's probably been 15.
Okay.
I mean, is there something that I should switch it up, or give him a break, or?
If he's been doing okay on it without side effects, I think that's fine. The one thing that with that particular medication, there's a couple things that we're going to go into it. So everybody's familiar. Risperdal is classified, and we're going to go into it as an antipsychotic. But as we said, it's used for a number of different things. So one of the things is, and we're going to talk about in a minute, is that one is very potent at something called the D2 receptor. So we have different dopamine pathways we're going to talk about. So it can go into the prolactin dopamine pathway, and by increasing prolactin, you can get like increased breast mass. And if you see that, you let the doctor know, because that could be the sign that prolactin's going up high, and the doctor would just get blood work to check that.
And how often should you be having blood work?
So it depends. They should be checking the cholesterol, blood sugars. They should be measuring his vitals, making sure blood pressure's not going up, because that class of medication, it can actually, we're going to talk about that too. So we're getting ahead of the game, but it's okay. So it's a preview to where we're going to go. It can cause weight gain. So that newer, we call them the newer generation, the second generation antipsychotics, they as a class, they can have a risk for causing weight gain. We don't fully understand the mechanism behind that, but one of the mechanisms is it increases, most patients you'll talk to say, I get the munchies from it. So it increases cravings for carbohydrates, sweets, fatty foods, so people can put on weight, especially if it's in this area is where the weight might go. If you gain weight in your waist area, we call that, you can get a metabolic syndrome. So that's where you can get the increased blood sugars, cholesterol. So they monitor all those things. There's actually usually state mandated things to monitor it for. If they haven't, just check. Be like, oh, what does his sugars look like? What does his blood? Yeah. Yes.
Regarding the questions asked.
Yes.
One of the things that I found very helpful, because I have ADHD, when I was getting diagnosed and trying to figure out the right medication, I found it helpful to keep a drug diary. But not only that, I would take my husband with me to the follow-up appointments, because when the psychiatrist would ask, so how's this medication working? I would turn to him and say, so how's it working? Because I didn't have the self-awareness to know how it was working. But I also would notify my coworkers and family members, by the way, I'm trying a different medication. Please let me know if you notice something odd.
Yeah.
Because I wasn't necessarily necessarily gonna know if I was gonna be wandering around in different rooms, you know, doing different things. And it was very, very helpful to do that.
No, that's fantastic. That's an excellent thing. And you could actually take those diaries with you to your appointment too.
Yeah.
So fantastic. Yes.
Sort of a subset of what she's talking about. How do you deal with someone that doesn't care about taking their medication and doesn't take it seriously? And or doesn't understand that you can't just take one pill and not follow a prescription? Because what she's doing is very smart, because she's documenting it and informing people. How do you deal with someone that's like so, anti, help that they won't even like take it seriously enough to do it?
Yeah, that's a very, very tough question. I wish I had all the answers for that. So unfortunately, there's different conditions.
Would you recommend maybe like upping the dose on something so that the effects are more like, you know what I'm trying to say? Because if she won't take the medication as prescribed so that it doesn't affect her, wouldn't it make sense to have like a stronger dose so it affects her sooner?
No, that's not good. So.
What if she never takes enough to actually do anything?
So eventually, at some point, that sounds to me like that person would end up in the emergency room potentially. She is, okay, and then inpatient. So when you don't have the medication at that point, you could have poor insight. So when you go into the emergency room and if they admit you, then they give you they can be aggressive in the
Medication there.
yeah, when they hospitalize you because you're in a 24-hour setting and the doctor is adjusting.
Because she won't be like cognizant at that point anyway. So when she's released again, she's not going to know that she needs to take the medication.
Yeah. So.
I understand it's a trickle question. This is what I live with
So a couple things to that. So hopefully I'm having a very optimistic view of it. But once we actually do get some medication in the system, hopefully that kind of brings more insight. So I don't know if she's still there or has come home yet. But
well, she has a prescription, but she won't take it, and when she does, she takes it so unregulated that it won't affect her.
Okay, so there are options for that. So, and it depends on what medication we're talking about. So the doctor, if somebody is really not, is forgetting or that's an issue, there's actually long-acting injectable versions of the medications.
She
So-
might not do that.
So that,
She is on Topamax.
oh, okay.
Is that, I was waiting to,
Yeah,
I
so
was waiting
minor
to
that I
reserve the question until the end of the question and answer period.
Yeah.
But is that something that you can actually not take every day?
So, and do you mind, I don't know if you want to share what,
I would love to figure out something.
no, I mean, share what condition
Oh,
that,
she's like bipolar, schizophrenic, and confrontational as hell.
okay. Okay, yeah, Topamax. I'm like, I don't think.
Everything, like countless, doctors we've taken her to, and she doesn't believe anyone, and she'll do it for like a very brief period of time until she feels like she doesn't need it anymore, and she just relapses like super hard.
So it sounds like, if she would be willing to have you, I don't know, does she have a doctor? Does she go?
No,
She doesn't?
tired.
Oh my gosh. She's seen the person that was also inpatient with her, just that person that's prescribed medication. They know what she's on.
So there's two different people, right? There's usually the therapist, they don't
And
prescribe.
psychiatrist, right.
And then there's a psychiatrist, so the psychiatrist prescribe.
Right.
So,
I have a suggestion.
yeah,
Next time she's hospitalized against her will, talk to the team there and ask about getting her injectable while she's there before sending her
yeah,
home.
that's what they usually do, is
Isn't
put
that
them
like a
on the,
temporary fix?
Well,
no,
they can last, weeks.
yeah.
Oh, really?
Maybe just long enough for her to get some insight.
And I was gonna bring about that, an adherence, so adherence was on our list. So Haldol comes in a long-acting, we also have Prolixin, so those are older generation, and the newer ones, we have Risperdal, but you don't want that for her, cause that's like a couple weeks, so Invega, can be a monthly, Abilify comes in a monthly,
Just monthly.
yeah. So that is usually what we do in those situations, because the doctors don't want,
I think
somebody
she
to,
just-
like, keep
she sees
coming
this
in.
Bottle, she's like, I don't wanna be dependent on this bottle.
yeah,
So that's what I'm trying to say, that's what she should do.
it's just the alternative way, yeah.
Sounds good, sounds really smart.
Yes.
I was just gonna, say, I'm a nurse and I And there are people that, if they end up in the criminal justice system and they are on probation, it can be a condition of their probation to get injectables. And they, if they wanna stick with their probation, and often they will, if it ever gets to that point, that's another option.
Yeah, we had, so my previous practice site in New Jersey was at Princeton House, and it was a 110-bed inpatient psych hospital. We had a couple detox units, a short-term rehab unit, we had a forensic unit. And our forensic unit, the psychiatrist used to bargain with the patient and be like, I will release you if you get the injectable. So because they were court ordered to be there, they were like, okay, fine, you know, give it to me. I want to go. So that was actually one of the things that got them to, the patients agreed to was so, but they were court ordered to be there. So, but you could work with the team if she's back in the hospital to try to get her on it, or with the current doctor. It could be, some people like that. They're like, oh, I don't have to remember to take pills. I just do an injection once a month. So.
That'd be way better, because I think she hates the idea that she's dependent on something and feels like it's making her weaker. I'm like, look, you should be happy that there is like this type of medicine in this day and age.
Yep, fantastic. These are excellent questions. So we'll keep going. All right, hold on.
Can we do questions at the end?
Yeah, so we can get through it. Okay. All right. So we'll get to antidepressants. So I think everybody can. I have listed the different symptoms of depression here, just so that we're aware that there's a number of different things. And the reason I wanted to list these out is that we're going to go through in a minute with antidepressants. They're all supposed to be equally effective. So when the doctor's deciding what to start, one of the things they look at is, well, what are the symptoms of depression you're presenting with? And then based on those, we kind of use the side effect profiles of the antidepressants to our advantage. And I'm going to go over those with you guys in a couple minutes.
Can you define psychomotor for people who don't know?
Yes, okay. So this is an excellent one because, you know, we have a questionnaire that's called the PHQ-9, and it's even confusing on there when you say, like, even when I'm asking people, they're like, what are you talking about? So it could be somebody who, it could be one extreme to the other. So somebody who's very fidgety and restless, or the other opposite end where they're like not, like they feel like they're talking so slowly, like other people couldn't know this type of thing. Now, does that make sense? So it could be either of those spectrums, but it's just a change in that. So we note that. But sleep is usually the presentation is having problems falling asleep, but in some cases it could be too much sleep. So that's the not the typical presentation. And then with appetite, usually it's a lack of appetite, but some people can have the opposite where they have too much appetite. So it's dependent on the person and their presentation. All right. So when I was having we were having a very interesting conversation about mechanism of what are the theories and do we fully understand the cause and everything of depression. And one of the theories that's been around for a long time, I don't know if you guys have heard of it, is the monoamine hypothesis. So there's three neurotransmitters that are thought to be the cause, possibly, and that's serotonin, dopamine, and norepinephrine. And we'll see in a minute, most of our antidepressants work on those neurotransmitters, okay? So the theory has been that, you know, so we have one neuron here, and then we have another neuron, so that's a presynaptic neuron, and then a postsynaptic neuron, and then the space between them is called the synapse. So once this neuron gets activated, it releases, let's say if it's serotonin that we're talking about, it releases serotonin, and that binds to the postsynaptic neuron, and it excites it, and that causes a relax. So you send these messages at lightning speed this way, right? The theory behind depression is that it's a deficiency between these two neurons. So let's say you have so little serotonin that these receptors start to increase so that even the littlest, tiniest bit, it can capture and cause that reaction. So what a lot of these antidepressants are doing, for example, something like a selective serotonin reuptake inhibitor, is preventing the serotonin from going back in here, so it's increasing the amount of serotonin between those two neurons. And what that does is over time, it causes those receptors to go back down to normal, okay? So that's why usually for the underlying depressed mood, it could take up to 6 to 8 weeks to see the full effects of that dose. That's been the theory. Do we fully know if this is correct? We don't. So it's a theory. And there's a lot of other mechanisms that are coming into play that possibly we're going to talk about in a minute. Ketamine is something that works at NMDA receptor. That one is something that's just been approved for treatment-resistant depression. For postpartum depression, there's been a new drug that came out that looks at a hormonal cause. So there's a lot of different mechanisms, and we're still trying to understand them. But this is one of the theories that's out there. But the reason that I like to show you guys this is that, I have quite a few patients who, and it's so nice to see like supportive family members that are here advocating for their family. When I'm in my patient groups, a lot of them tell me it's quite the opposite, that they have family member that tells them just snap out of it, And, I reiterate to them that I show them this, and I show them, this is a physiologic condition, just like someone living with diabetes. You can't snap out of diabetes and not need your insulin, right? And this is what our medications are. These are physiologic conditions. It's just like someone living with diabetes needs their insulin. Someone living with a condition like depression needs their antidepressant, especially the studies have shown if it's moderately to severe depression is where we see that difference between placebo. So it's a vital part of the treatment. So we have quite a few different antidepressants. So I am not going to go into these older drugs. We really don't use these anymore because they have such bad side effect profiles. They're really more of like, if you've been on them for a long time and they work for you, or maybe if you have a pain condition that maybe a tricyclic antidepressant like Elavil or something they might start. But generally we don't go to those first line because of the side effects. So we have our go-tos are the newer ones. So we talked about selective serotonin reuptake inhibitors. So these work just on serotonin. So that's Prozac, Paxil, Zoloft, Celexa, Lexapro. And then Luvox is in here, but this is one that is utilized for OCD is what it's really used for. And then serotonin norepinephrine reuptake inhibitors, we have Effexor, Pristiq, Cymbalta, and Fezima. And out of these, usually Effexor and Cymbalta are the ones that are the most cost-effective that people go to first with the serotonin norepinephrine. So those work on serotonin norepinephrine. And then we have bupropion, which comes in a number of different formulations. It comes in an immediate release, a sustained release, an extended release, and then there's even like ones that are branded that have so there's a lot of different forms of bupropion. So I'm going to just go into a couple of different things about these medications for you guys. So how do we utilize the side effects to our advantage, right? And I have it on other slides coming up. So if I see that mostly during the day you're tired and you're feeling really like low energy, right? And that's one of the main symptoms that you're having and you're depressed, then something like a Prozac or a Wellbutrin might be a good option because those are the ones that are really activating, meaning they're the ones that are gonna like give you a lot of energy. So those are given usually in the morning or else you're gonna be up at night. So and hear me out when I say, I'm going to say usually a lot during the presentation, so does it mean everybody experiences that? No. So if you ever have the opposite of what we would expect, always let your doctor know they can change the timing of the medication and stuff. So for example, if I always think Prozac makes everybody awake and then it makes you sleepy, then we don't want to give it to you in the morning, right? We don't want you to be sleepy during the day. So then we have other ones.
When would Prozac make you sleepy? I thought serotonin is more of like a relaxing, calming, and so it's surprising that you say that.
It's specific, so it's not necessarily serotonin. It's specific to the medication because it's not. Each of them are not just working on serotonin. They're actually working on a number of different receptors they're hitting. Like for example, Paxil tends to have like kind of a messier side effect profile because it's hitting a lot of other things. It's one that is on the Beers list, which is a list of drugs, potentially inappropriate medications in the elderly. So it's really anticholinergic, so it can really dry you out. So they have like a number of different properties besides just the mechanism we're looking at, that's kind of why they have a little bit different side effect profile. Okay. So Zoloft is an interesting one. It's probably the one that I've seen that doctors go to as like first. That's like their go-to. And the reason they love to go to that one first is that it's got such a wide dose range and it's usually really well tolerated. Okay. The thing about Zoloft though is it can be out of all of them kind of more messy on the GI system. So it's one that if you take with food, maybe you'll tolerate a little bit better. And there's some things to say that you might absorb it a little bit better with food too. So Zoloft maybe taking with food would just be a win-win in that case. And then Celexa and Lexapro are, and I don't know why I don't have, oh no I do. They're very similar. So this is just the more, it's like the mirror image of it, but just more of the good side without the bad side. I don't know if that makes any sense. So usually Lexapro is the purest of the SSRIs. Any of them that work on serotonin you see there are usually really good on not only helping with depression, but also helping with anxiety. And we know they kind of go hand in hand. So a lot of times, for example, someone living with depression may also have generalized anxiety disorder. So, so it's a kind of like a win-win with these medications that work on serotonin. So the doctor might be like, okay, well, I'm going to start you on Prozac, or I'm going to start you on Zoloft, which can help you with both anxiety and depression, okay? But just a little caveat about that. So they're supposed to help with anxiety, but initially they might make it actually a little worse, especially even at starting doses. So if you have anxiety, the doctor might want to be a little bit more cautious with the starting dose and titrate it a little slower. So, so usually that's why they might do, like sometimes they do like, you know, like for Zoloft, they might say like take a half a tablet for a week, then if tolerated, increase to a whole tablet or something, because it can actually make you a little bit more anxious. So if you're feeling more anxious, let the doctor know. They might tell you, oh, it's okay, or they might decrease it, okay? But it should help with anxiety long term, but it won't do it right away, okay? These can actually help with depression and pain, so that's a win-win with those, with the ones that work on serotonin norepinephrine. So if you have high blood pressure though, especially with Effexor, it might be a little bit more. I would just be cautious with that class because they could affect the blood pressure, especially Effexor can, as they increase the dose too. Might see that more. It's like a dose-dependent effect on the blood pressure. And then Wellbutrin is interesting, and we'll see in a minute. That one is one that with Wellbutrin, it can be used off-label to help with attention. They use it in kids for off-label for attention deficit. It can help you quit smoking. It's an antidepressant, but unlike a lot of these, it doesn't really have that risk for causing sexual side effects. So a lot of the serotonergic ones can have sexual side effects associated with them, but that one is not likely. Sometimes they add it on or switch you to Wellbutrin if you're having sexual side effects. So if you ever experience that, don't be afraid to let the doctor know. And while we're on that subject, before I forget, there's a rare side effect. So it's called priapism, and I've seen it in a couple of patients. So it's just something to be cognizant of. I believe with trazodone, and I've seen it with a couple of the antipsychotics, where it's a prolonged erection that's lasting. That could be it's an emergency because it can cause damage. So if that's happening from the medication, you need to go to the ER.
Which meds?
I'm sorry?
Which meds?
Trazodone is one, and then with antipsychotics, it's so rare. We just had a patient who had it from, I want to say Seroquel. I don't remember exactly which antipsychotic, but we had to take him to the emergency room. So it's just something to be aware of.
Is there an equivalent to that in women?
No, not to my knowledge, but yeah.
Question?
Yeah.
Just SNRIs, what were the two kind of symptoms that they were good for?
Oh, they not only depression, but they can help with anxiety, and they can help with pain conditions. So Cymbalta has indications to help with fibromyalgia, neuropathic pain, can help with like back pain. Effexor has off-label, it has good studies for neuropathic pain, but the last time I checked, I didn't see as strong as studies as we have for Cymbalta for fibromyalgia. So if somebody had fibromyalgia, maybe Cymbalta might be a better option. But with this one, if you have any kind of liver impairment with Cymbalta, it's not a good option. So if you have like a history of any kind of like hepatitis or cirrhosis, then I would not do Cymbalta. If you have a seizure condition, this medication is not good, Wellbutrin, because it can make it easier to have seizures. We don't want you guys to have seizures, okay? Also, if you have a history of an eating disorder, the Wellbutrin or alcohol, misuse of alcohol, they can cause electrolyte imbalances, which can make it easier to have seizures. So Wellbutrin is not a good option if you have a history of any of those things.
What are eating disorders? Because it's used for addiction, why would it become indicated for eating disorders?
So in two specific types of eating disorders. So bulimia and anorexia, because of the electrolytes. Not binge. I don't see any reason for binging. Yeah. All right. So as we stated, these are our first line options. So time to onset. So I always tell patients, initially within that first week, you might see improvement in your appetite, energy, sleep. And then you see there within 1 to 3 weeks with some of the other things, but the underlying depressed mood can take a while because we talked about one of the theories is that because of that receptor downregulation. I tell patients to be patient about letting the antidepressant work. Usually doctors within 4 weeks, they do follow up and then they adjust the dose if needed at that time. But it can take a little while to see the full effects of that dose. Okay, we're going to go through in a minute. So we talked about antidepressants with lower risk of sexual side effects. Bupropion was one, which is Wellbutrin, and another one is Remeron. I didn't talk about Remeron, but Remeron is an interesting one where it's one that can help you with sleep and it can help you with appetite. And it's used for depression. So it's one that I usually use a lot, like in our patients who we definitely want to see the appetite increase, and then or if they have sleep issues. So what are the symptoms of? So let's say I've been on an antidepressant for greater than or equal to 8 weeks, and then I suddenly stopped it. What happens? How do I feel?
Insane.
Well, yeah, it could feel pretty bad, right? So we can see here, so you can have like flu-like symptoms, brain zaps, very vivid dreams. It's highly uncomfortable, right? And this is a quick trick question because I ask my patients, is it life-threatening?
You can feel it, sure.
So you're physically not, so it's not like a benzodiazepine, like with Ativan or Xanax or any of those benzos that if you take them for a long time, you suddenly stop them, you could have a seizure, right? It's not like that. So it's not like it's life-threatening where you can't have a seizure from stopping it, but it can be life-threatening because the symptoms could come back, right? So in that way, that's why I say it's a trick question because the symptoms could come back. But you can see it's highly uncomfortable. So if your doctor's trying to take you off or tapering it even, and usually the most notorious ones, the hardest ones to come off of are Paxil and Effexor. So if you start noticing you're having any withdrawal symptoms, it'll happen start within a couple days in that first week. Yes?
I actually was titrating off Effexor and had the brain lightning,
Mhm.
as I call it, which was horribly uncomfortable. I actually took the capsules apart, counted out these
Wow.
capsules, and got gel capsules so that I could make the titration more gentle. My psychiatrist thought that was a little excessive, but it helped because that was nasty.
Yeah.
And I had it for months.
Yeah, it can. So I've seen it very rarely last a very long time. Usually it doesn't. So what we usually do in that situation is the doctor will take you back up to your previous dose before you had the symptoms of the withdrawal, unless you were being taken off of it because you had some kind of reaction that you had to go off of it, right? Then we have to look at other things. Like sometimes they switch you to Prozac because it stays in your system for a very long time to help you get off of. What they would do is usually they titrate you back up and then slow down the taper. Okay? So let your doctor do that. So,
Well, I worked with him, but it took a long time.
yeah. All right, so we talked about this already, so selection based off of target symptoms. So does it mean that everybody who has a target symptom, we want to do this one? No, because each person is going to respond differently, okay? So the doctor looks at multiple things. One of the things that they might want to know is if you have an immediate family member, let's say if I was diagnosed with depression, and then the one thing that I would want to let the doctor know is if I, for example, had a mom or dad or a brother and sister who did really well with, let's say, Zoloft, then maybe that's a good, so that might be a good option for me as well. So usually if like an immediate family member has responded to one medication, the doctor, it would be good for the doctor to know that and evaluate, is that a good option for you or not? So, so there's a number of different things that we look at when we're deciding. And here is based off of the comorbid condition. So we usually said the ones that have work on serotonin can also help with anxiety. So tamoxifen is an interesting one I put up here. So it's a medication used for breast cancer, but and depression does come, a lot of patients that have that condition also have depression. So unfortunately with tamoxifen, which is used to treat breast cancer, it needs to be broken down to its active form. But there's some antidepressants that can block that from happening. So it's important that they put they start the person on one that doesn't interfere with the tamoxifen. So that's why if you're on tamoxifen, then there's like a limited amount of ones that we look at that don't interact with it. Okay, because we want it to work. We want that tamoxifen to work. So, and then if we look at high blood pressure, we probably would want to avoid the ones like Effexor. If someone is concerned about weight gain, bupropion has very little weight gain, maybe weight loss, and then the vilazodone, which is Virid, that one also doesn't really have the weight gain associated with it as another option. That one has a lot of gastrointestinal side effects. Just FYI, Virid.
Which one?
Virid.
Which one's that?
Virid, vilazodone. So I had a patient once who was on a lot of medications to help with their constipation, and then on top of it, every antidepressant known to man was making them constipated. So I'm like, this one really has like a high incidence of diarrhea. And then there was like a miracle thing. She's like, oh, I got off of my other. So it was a win-win. And then the pain syndrome. So we talked about those. Pregnancy. So I try to avoid Paxil in women of childbearing age because it's pregnancy category D, and if you get pregnant, it's one that we probably wouldn't want to be on because it can cause defects in the baby. So, so we try to look at which ones might be a better option. And Zoloft tends to be one of the ones that they use because you can continue it in breastfeeding. So Zoloft, yeah, because it doesn't really cross into the breast milk. Then we have sexual dysfunction we're talking about, and smoking. So this is just a quick picture for you guys about serotonin syndrome. It's extremely rare, okay, extremely rare. But so serotonin syndrome just means, too much serotonin can actually be bad too, right? So usually this is not a concern unless you're on multiple medications that are increasing serotonin. We look out for it. Or if you're on one of those older antidepressants, it can increase your risk with certain medications. And then there's an over-the-counter medication that I absolutely try to avoid because it can cause serotonin syndrome and interact with a lot of meds. It's called St. John's wort. And if you guys have heard of that. Yeah. So that's not good because it can interact with a lot of them. So I usually just say anything over the counter, talk to your doctor first, okay, before starting it. Talk to your psychiatrist, yes.
Are you saying that's a concern using St. John's wort alone or in conjunction with these other meds?
With these other meds, because that would cause that also affects serotonin. It would increase the yeah. So I would definitely talk to the doctor if that you're and let them know. So the doctor should always know if you're on any herbals or supplements or anything. But here, if you notice, it's like sweating, a kind of confusion, inability to coordinate movements, the sweating, the high vitals. The temperature is going to be up, possibly because of all this movement. Okay, so you're going to have all this movement, which is increasing that temperature. And usually, if it's severe serotonin syndrome, then they don't have to give like a a paralytic and kind of intubate the person to calm them down to get that temperature down. So, but it has a range. I'm sorry?
Would that be associated with high blood pressure too?
It's just a multitude. So it's a lot of these things can sound like other things, but like when you're looking at serotonin syndrome, one of the bigger indicators is that clonus, that movement, the really high temperature, for example, where you're getting into that range. Okay. So that's a whole different thing. We'll talk about. And then there's a black box warning with antidepressants for suicidality. So this is, the risk was shown to be with certain ages. Okay. So if you see here, it's you didn't really see that in adults older than 24 years. So it's in children, adolescents, and young adults. Okay. Oh, this is one of my favorites. Okay, can you become addicted to an antidepressant? What do you guys think?
It's how you define addiction. I mean, if it works.
So that's an excellent answer. It's how you define it, right? So when I did a lot of outreach for antidepressant adherence, one of the common things I would hear was patients saying, well, I just stopped it because I didn't want to become addicted to it. And I want to tell everyone right now, no matter how long you've been taking antidepressant, you cannot become addicted to it, okay? Yes?
In that spirit, are you talking about addiction being, experiencing withdrawal symptoms without it?
So that's where I was going. You were like 1, 2, 3 steps ahead of me. All right. So you got to define it, right? So you got to look at dependence versus addiction. So I think of dependence as something more physical, and I think of addiction more as something that has to do with our mind. So when you look at, if you start anything, right? You've been starting, let's say you start an antidepressant like a Lexapro. You've been taking it every day, right? You've been taking it for more than 8 weeks that we talked about. What's going to happen if you suddenly stop it? You're going to get all those symptoms, right? We talked about somebody says it feels like hell, right? So your body is showing that you had built a tolerance to it, right? And then so you're showing withdrawal symptoms. Does that mean that you're addicted to it? It shows that you're dependent. So the addiction, I think of addiction as, are you going to go and stop and do something illegal and stop at nothing and put everything aside to attain Lexapro? No, right? It doesn't have that psychological component attached to it. So it is not a controlled substance. So controlled substances are things that are in that way. So no matter how long you take Lexapro, you will not become addicted to it. I'm telling you that today. Okay? So don't worry about that with your antidepressants. Okay. All right. So this is just to show you guys. There's actually been a number of antipsychotics that have FDA-approved indications for different conditions in depression. Okay. And then treatment-resistant depression, which doesn't really have a clear definition in the guidelines, but when you look at different places, this is a consensus that I see as at least 2 adequate trials of antidepressants. So what does that mean? Adequate doesn't mean you started it for 2 days and you stopped it. It means you took it at an adequate dose for at least 6 weeks or more, okay, and it didn't work. So at least 2 different antidepressant trials at adequate doses can be defined as treatment resistant, possibly. So there's a number of different options that we can look at that point. Sometimes doctors add on medications to an antidepressant. Sometimes they'll add on lithium. Sometimes they add on antipsychotics. There's a number of things, but there's actually, I don't know how many of you guys had heard of ketamine? Okay, so a lot of places do ketamine infusions, but these are off-label. I don't know if there's coverage from the insurance. Anesthesia does them, but there was a recent medication, and no, they are not paying me. I'm not representing them. Remember, I have no disclosures. They did this just got approved last year as a nasal formulation of esketamine. So, and it was found in the trials to be effective for treatment resistant as an add-on to the antidepressant. So there's more work to be done. So this is all new stuff that's coming out. But it's just nice to see these new mechanisms besides what we've had and options, because pretty much most of in our treatment resistant clinic before these new options, we just had ECT, and sometimes we use TMS. So patients want other options. Sometimes patients don't want to do ECT. So this is just something else. But one of the caveats is it does have, it's a form of ketamine, right? So everybody's familiar that ketamine is a substance that can be abused. It used to be what, a club drug? Yeah. So there's a lot of reasons why dissociation is one of the side effects that can occur. You can see here it's one of the most common side effects. And it can make you sedated, and one of the things they look at too is blood pressure with this one. But because of all the risks that can be associated with this new medication, it's not something you get to take home. So if the doctor prescribes this, you have to go in at the beginning twice a week, and then after I think it's a couple weeks, it becomes once a week or every other week. And then they don't know how long you need to stay on it. That could be lifelong that you have to do this, and you can't drive to the appointment, and you can't drive home. You can't drive till the next day. But a couple of reasons that they did that is because they want to monitor you for 2 hours and make sure that you're not having any of these side effects before they let you go home. And then the other thing is it's a drug that can be abused, and the FDA didn't want it something to be that you took home to abuse. But there's no IV, and it's through the nose. So when we looked at it, we decided we're like, IV ketamine or this one where I am, and we were like, this one they get more face time with the psychiatrist. Our psychiatrists, every time they come in, they see them. So it was just something we haven't started yet. I have no idea how it's going to turn out. If I come back in a year or two, I don't know. I'll let you guys know my experience. So I don't have experience yet with this medication to share experiences with you guys. So these are just some things, FYI. I'm going to skip on to... It shut me off. Oh no, it's rebooting. No.
No.
Okay.
Is that the right program?
I think so. Okay. All right. Okay. So what are the antipsychotics helpful for? So they can help with a number of different things, right? If we see here, these are some of our different types of target symptoms. Just to give you guys some definition, delusions can be a fixed wrong thought. Okay, it could be something where you think something, but that it's not reality, right? And then hallucinations is things like if you're seeing or hearing things that are not there. So the medications, they can target these things, right? But as we talked about earlier, there's a number of different things they can be used for, and we'll talk about that in a minute. So if we look at the response time within the first week, you can get improvement in agitation, aggression, and sleep. But the hallucinations and delusions can take a little bit longer to see improvement, and then we have improvement in our cognitive symptoms. Doesn't happen with the older generation, but more likely with the newer ones, and I'll talk to you in a minute about why. Okay. So if we look at, and I think, did I skip a slide? Let me just go back for one. It keeps doing that.
Blank slide in there.
Oh, I think it
doesn't like that slide.
now it's like, we need a break. No, I'm kidding. It's trying to tell us something. I don't know. Let's see. Sorry, everyone. Let me go back here. Okay, we got through that slide. Okay, so these are our older generation antipsychotics. I just wanted to point out a couple things about them. So I have kind of grouped them together based on how strong they are by going. So their main thing that they do is they go and they bind to the D2 receptor is where we want them to go, and they how strong they are at that receptor can affect their side effect profile. So Haldol, flufenazine, those are more potent ones. So they bind tighter to there, and that's why they can cause things that we call movement side effects. Okay, so movement side effects can be things like you look like you have Parkinson's when you don't. It can be tremor. It can be kind of stooped over, shuffling gait. One of the other ones is akathisia. So akathisia, I don't know how many heard of akathisia. That's an important one to know, because it's like an inner restlessness where you're like constantly having to move, like your legs are moving, everything's moving, and you feel like you want to jump out of your skin. That could be due to a medication.
What's it called?
Akathisia. Yeah. Medications like Abilify might be kind of one of the ones more likely to cause that than some of the other ones. But it's just something to be aware of, because if you're experiencing that and don't know what it's related to, that could not be good. Okay, so that's something important to be aware of. And then the ones that are not as potent, like Thorazine, for example, those can give you more of, we call them things like anticholinergic, kind of dry you out, and kind of make you sleepy, and then can affect your, make you dizzy. So more than the more potent ones. They have a little bit of different side effect profiles. And here's the different movement side effects that we were talking about. Tardive Dyskinesia is one where one of the more areas that you might see it is in the mouth, where it's kind of like a worm-like movement of the mouth, for example. That's one of the ones that you don't see right away. It might show up later. So if you ever do see that, it's not common. I just want you guys to be aware. I don't want to scare anybody about it. But just let the doctor know if you see it. Previously, we didn't have treatments for it, but there actually is treatments now. So one of them I think is called Ingreza. So at least we have something that could potentially be helpful if that happens, which is not likely, but just to be aware of. So these are our.
You said mouth, I thought dyskinesia often in the legs.
So the place that I commonly more see it is like here in the mouth area. So it's kind of like a worm-like movement of the mouth that you might see. It's called Tardive Dyskinesia. Yeah. All right. So if we look at second generation antipsychotics, we have our newer. These are all newer, but I divided them up based on, so you guys are aware which ones are brand name and are very expensive because they're brand name. Because I know that your insurances usually have tiers, right? Even if it's covered, it's like tier 1, tier 2, tier 3. So it could be a bigger copay if you don't need to be on a more expensive medication. So sometimes the doctors may not be aware, and it might be something that drug reps are coming by and they're like, oh, this is the best thing since sliced bread, and they start giving it out to everybody. So and they start samples, and then you don't realize the coverage. So it's important for us to just be aware of that. I try to be mindful of that. Even before discharge, if we start on something that's expensive, we want to make sure that you're able to continue it when you leave, right? Or else what's the point to start you on a medication that you can't stay on? So, yes.
Previous side effects, they also can apply to these, correct? Some of those?
Yes.
You can have tardive dyskinesia.
It's possible, but it's, for example, the ones that are not as potent, like it's not likely with, I don't see that with Abilify, or like Seroquel is one that is less likely to have movement side effects, for example. So if I have a patient, for example, who has a history of actual Parkinson's, and I have to put them on an antipsychotic, I might do a Seroquel because it's not as potent to cause worsening of their movement side effects.
Do you ever see the Parkinson's with the Abilify? Type the more pseudo
The Parkinson's, I see that more with like Invega or Risperdal. Just those are more potent at that D2. So we have, sorry that it blanked out on some of those slides. One of them showed the different dopamine pathways. So we have a dopamine pathway that regulates movement. It's called the nigrostriatal dopamine pathway. There is a dopamine pathway that regulates cognition, that's mesocortical, and then we have the prolactin one, which is tuberoindenfundibular, and then the very last one is mesolimbic. So the aim, what we want, is for the antipsychotic to go into the mesolimbic dopamine system and block dopamine there, because the excess is what causes people to, for example, see and hear things that are not there. But unfortunately, the more potent they are, they can get into those other dopamine pathways and cause side effects, right?
So if somebody did appear to be having, I'm just talking about my family, when they put my son on Abilify, and I saw him a few not even 2 months after,
Mhm.
I know what Parkinson's looks
Yeah.
like, because I'm a therapist, occupational therapist.
Mhm.
He looked like somebody with Parkinson's.
Then I would definitely let the doctor in.
I did, and they did nothing.
Oh,
It
they
took
did.
months to get him
Okay.
to lower it.
Okay.
My daughter had a mania that was induced by Latuda,
Okay.
and I'm wondering, but she's fine on Abilify, so I'm just wondering why it seems, I haven't found a lot of information on why an antipsychotic would trigger mania,
So that could be a couple different things. I'm just trying to think without having access to the records to get the full picture of what was going on.
Not as a diagnosis, just information
Yeah.
about these classes.
So it's interesting because, and we're going to go into in a minute with what you're segueing into is right here. Can antipsychotics be used as mood stabilizers, right? Because if we're treating, and I'm thinking what you're stating is, yeah. So Latuda, one of the things that Latuda we can use it for is the depressed phase of bipolar, for example. Abilify is one too that we can use in the mania, but it's not as good. We don't use it in the depressed phase. So I think that was probably just a better option to control her symptoms in that case, is what it sounds like to me. If I'm thinking of something inducing mania, I think of antidepressants, right? Because the antidepressants can take you from you think it's depression because because bipolar is kind of this roller coaster that can happen, right? You have the depressed phase, which exactly, the symptoms can resemble major depression. And then you have the peaks, which those are, it could be mania, right? So someone may have been here before they ever got up here. And then once they take that antidepressant, it switches them to that mania, and then we realize maybe the diagnosis is something the doctor's working on. I don't know. I don't diagnose. So if there's any therapists here who want to chime in on that, because I don't diagnose, it's not in my scope. But this is how it's been explained to me. So I think the one thing we're cautious about is we try to avoid antidepressants in bipolar unless you're stabilized on a mood stabilizer. Because the mood stabilizer serves as a protective factor, so it helps prevent you from being switched into mania. Okay, so in that case, I think that was probably that just wasn't the right med, and they got her on the right med to treat the mania. Yeah.
Well, we had a new experience recently where my brother was put on Reuptake,
Yeah.
and within the first week, he was extremely dizzy, and he had memory loss. And he's been taking many different medications for decades. But the side effects were so severe that quickly. And I'm just wondering, and he went to his doctor and he took him off and all that, but I had never seen side effects come on so quickly.
Yeah, and each person's different with how they respond, and they can definitely occur quickly depending on what medication it is and what side effect we're talking about. So, so it's very likely that happened, and that one is one of the newer ones. It's very expensive, and I don't know what other medication were they able to.
They put him on Risperdal.
Okay.
And he's also on Clozaril.
Oh, he's on Clozaril. Okay.
And a few others, but anyhow.
Which we go back to Clozaril.
Yes.
So out of all of them, Clozaril is the only one that's been proven in treatment-resistant patients to be superior.
And
Okay.
that was the case.
Yeah.
It gave my brother his life back.
Yeah, and that's what a lot of people say. The reason we just don't go to Clozaril is because it has, because of the side effect profile. If I even showed you a picture of it, you'd see it can be a pretty messy drug. It hits pretty much all these different receptors and can have side effects, from making you dizzy to, and that's why they titrate it so slowly too. It's also one that we have to do blood draws on to make sure that it's not affecting the neutrophil counts, because there's something that can happen. It's called agranulocytosis. So the first 6 months, they usually check the levels every week, so they don't even give more than a week at a time. And then after 6 months, if all of the absolute neutrophil counts look okay, then they do every 2 weeks, and after that, every month for as long as you're on Clozaril. With Clozaril, just one thing to be mindful of, if he misses taking the doses for greater than 48 hours, which is 2 days, then they need to retitrate it back up. So you can't, he's programmed, fantastic.
You know, monitored. It's wonderful.
Okay, fantastic.
They're on top of it.
Yeah, but that is a medication that definitely for treatment-resistant cases can be life-changing. There's also other patients that it could really benefit if there's a lot of aggression or a lot of suicidal thoughts that can also help with those things as well. So with Clozaril. So I talked about weight gain with these newer ones, so we don't get as much of the movement side effects with these newer generation antipsychotics, but they do have as a class of warning for the weight gain. So I always try to tell my patients, try to make more healthy decisions when you're, I mean, if you're getting craving for ice cream, take the outside of the banana off, for example, and then freeze it and then make a shake or something, substitute it with something healthier, because it's not an overnight weight gain. Okay, so a lot of them tell me, I keep getting these cravings and it's in my what I'm eating. So try to be mindful of that, and the doctors monitor the weight, so they should be monitoring the weight. If you're noticing significant weight gain, it's definitely something to bring up to the doctor. Okay, it won't happen overnight, but just keep track of it. Okay. And then just with the antipsychotics, we talked about this a little bit earlier. There's a couple that you have to take with a meal, and it's actually a certain at least a certain amount of calories to get the full absorption of the medication. So if you're on Latuda, they usually say you have to have a meal that has at least 350 calories, and then with Geodon, at least a 500 calorie meal, okay? Or else the absorption can decrease by half. So
why would you choose one psychotic drug over the other? Why would you choose Geodon versus another one?
So it all depends on the patient, their presentation, and what we're trying to, and it could be doctor preference too. So it's a number of different factors about what we decide. So if I look at the patient-specific factors, for example, if they're having a lot of problems with sleep, I might do a Seroquel. Seroquel we even do at low doses to help with sleep, and then it can also be used as a mood stabilizer. So we look at a number of different things when we decide to, and then Seroquel, for example, can be used in the highs and the lows. So
and Geodon? Because I had a client on that, but I'm not familiar with Geodon.
Yeah. So with that one, I don't have too many pearls with that one. It's just, it can be a mood stabilizer, it could be the other way. It all depends on what they respond to. So I don't have very, very definitive things with that one. So I think everybody knows, yes, we can use antipsychotics as mood stabilizers. And just mood stabilizer is anything that's preventing you from, which treats a phase of bipolar depression without causing either. So we definitely know antidepressants are not mood stabilizers, right? If anything, they're going to switch you possibly to mania if you have a history of bipolar disorder.
Could you repeat that?
So mood stabilizers are not, I'm sorry, antidepressants are not mood stabilizers, because they can actually switch you into mania. So, yeah. I don't know, did that answer your question? I don't know what's going on with my computer today.
It's very moving.
Sorry, everyone. I know it's oh, here we go. Okay.
You did it. You did it.
No, not quite.
Okay, so we get a full screen mode. Okay. All right, fantastic. Yay. So we talked about this already. I'm just going to flip through this real quick so we can get through a couple different things. So for the pharmacologic treatment, yes. Lithium.
What about lithium orotate? It's over the counter.
No.
Okay, thank you. That's all I wanted.
So people are not aware that there's actually a form of lithium available over the counter. Not good.
Because
Not
it
good.
can't, it's not
It's not regulated, and especially something like lithium, where it has such a narrow range from where it can go from an effective to a toxic dose. And over the counters are not regulated. I don't even know how much is in there, so I would never take that over the counter.
It's not related to the lithium or something?
So it is an element on the periodic table, lithium, and it is a naturally occurring element, yes.
They are the same.
Yes, so you actually might have some lithium in your own system. Everybody might have a little bit of that. So it is something that's naturally occurring. Okay, and what's interesting, it can act like salt. It goes through purely through your kidneys. Okay, so it's something that we're going to talk about in a minute. Anything that can affect the kidneys can actually affect your lithium levels, especially things that if you become dehydrated, or these are really important things that you need to be aware of if you're on lithium. Okay.
What are the symptoms of people who are excessive lithium?
Oh, we're going to go into that in a minute. If this wants to. We went to insomnia. We don't need to go there.
This one?
No, keep going. Here, let me go to this one. I got it. Let's do it. This might work better. I just changed it from PDF to PowerPoint. All right. Okay, so I'm just gonna flip through. All right, so if you're having like these kind of symptoms, like if you're having loss of balance, slurred speech, these are not good. These are definitely things that show that lithium could be very high in your system. Okay. Some common things that could happen is like you can't feel tired. That might be something that can improve over time. Nausea, if you get that, you can try taking it with food, see if that helps. So we talked about the antipsychotics can cause weight gain, that are the newer generation ones, right? Also lithium and Depakote, possibly something we should monitor just to see if you're putting on any weight with those as well. Okay. If we go to examples of side effects you should report right away, we talked about there, if you're having watery stools, diarrhea more than twice a day, basically if you're getting dehydrated, that could affect the lithium levels. So it's really important to let the doctor know. If you're having abnormal general weakness or drowsiness, marked trembling, muscle twitches, jaw shaking. So these are just the important considerations. So usually on the unit, when I tell my patients, I'm like, I want to see you with the big jug of water. If you're on lithium, you're like walking around drinking that water. So they all have their little the jug, and they're drinking it. Usually at least 8 glasses would be good, at least, of water or some kind of fluid to, yes.
Can that be, the other extreme of that also? Can too much water flush that out of your system?
So what we would, too much water. So I don't think I've had that. I think the main concern is we're worried if it goes toxic. So we want to make sure you're drinking the water, okay? So make sure you're hydrated, limiting the number of caffeine drinks that you're having, okay? Another thing that can cause toxicity is, I always tell my patients, I'm like, if you're starting lithium, things like ibuprofen, Aleve, all those Motrin, all those non-steroidal anti-inflammatory drugs can actually cause lithium levels to go up too high. It's not good. So a safer option might be Tylenol, but talk to your doctor and see if Tylenol is something that's safe for you. So some people may have liver issues or it may not be a good option. But they could talk to the doctor about what is a better option if they're having any kind of pain, because the NSAIDs we want to avoid. Okay. And then if you have, sorry, it should not have an E at the end. If you have the flu, not flu-y, especially if vomiting or diarrhea occur, check with your doctors. And we talked about that. And then I tell them, you know, when it's really hot, they should just make sure, you know, because you can lose a lot of water and you lose salt that way and you can become dehydrated. So make sure that you're drinking the fluids. So with some of the other ones, with valproic acid, with that one, so we talked about with lithium, it was more of the kidneys. And they also look at the kidneys. So lithium, if you're on lithium, they check your thyroid, make sure it's not affecting the thyroid in any way. And they also look at the kidneys to make sure it's not affecting the kidneys. With Depakote, they check your liver, see how that's doing when you're on the Depakote. And also with lithium and Depakote, they also monitor to make sure that the levels are in an okay range. Okay, so you might get, if you're on those medications, you get blood work. Okay. I'm gonna just go quickly some of the other ones. Yes.
Yeah, just going back to the anti-epileptic. We have a family member who's been on Lamictal for a really long time, and it's been really effective for their bipolar disorder. Stopped having manic episodes for over 5 years now, and it's been really good. But, you know, their mood is not at a very kind of good place, kind of fairly depressed. They tried antidepressants previously together, and it would go into